Hi, my name is Hillary Goldberg, and I'm the Medical Director of the Lung Transplant Program at Brigham and Women's Hospital, and I will be discussing ICU issues for the transplant recipient. Today in my talk, I will provide some basic background, talk about some of the underlying disease and comorbidities that affect the outcomes of transplantation, some issues related to donor evaluation, and then focus on evaluation of the transplant recipient in the perioperative period. We will focus on technical issues, infections, immunologic concerns, and medication side effects. To provide some background, here is data from the American Journal of Transplantation, which demonstrates the frequency of listed patients for kidney and liver transplantation and for other organs, as well as patients who receive transplants. What is notable here is that patients are much more likely to be waitlisted than to actually receive a transplanted organ. This leads to issues related to waitlist management, as well as the acuity of illness in the transplant recipient, and these factors may impact outcomes post-transplantation. In addition to the wait time, there are multiple factors involved in transplantation that may impact the ICU management. Particularly in recent years, there has been an evolution in transplantation across all solid organs. In general, most programs over the years have liberalized their acceptance criteria for both donors and recipients. This may affect increasing acceptability of increasing age in both donors and recipients, as well as evolving allocation systems that prioritize patients who are the sickest and therefore most urgently in need of a transplant. At the same time, mechanical circulatory support has evolved in its sophistication and has become more routine in the management of waitlisted candidates as a quote-unquote bridge to transplantation. The result of this evolution has led to increased acuity of the recipient at the time of transplantation, with an increased likelihood of an ICU stay before and after transplant, as well as potential donor factors that can impact the immediate post-transplant course. This may lead to a more complex ICU stay and most certainly requires comprehensive multidisciplinary management of the recipient, as well as ongoing need for quality assurance and process improvement to ensure that the factors that we liberalize on are effective in maximizing transplantation while minimizing complications. For example, liberalization of acceptance criteria has led to more and more complex medical comorbidities in the setting of solid organ transplantation. As you can see in the figure, in the setting of lung transplantation, patients with poor RV function have a worse survival compared to those with preserved RV function. And this leads to more complicated perioperative and postoperative management. In addition, secondary organ dysfunction has become more common in the setting of solid organ transplantation, and this can complicate the perioperative management. As mentioned, mechanical circulatory support as a bridge to transplant has become more common, particularly in the setting of the Avalon catheter, which is demonstrated in the illustration on this slide. You can see that the Avalon catheter is a dual-lumen, single-stick catheter, which is placed in the neck and allows for increased functional capacity in lung transplant candidates, as well as in heart transplant candidates. This allows for support with ECMO, or extracorporeal membrane oxygenation, as a bridge to transplant. This can be used in the setting of both hypercapnic respiratory failure, hypoxemic respiratory failure, as well as for cardiovascular support. In experienced centers, the 30-day and 1-year survival rates are comparable for those patients who are bridged with mechanical circulatory support and those who do not require this intervention. As I mentioned, donor criteria have also been liberalized in the last decade. In the early days of lung transplantation, for example, you can see some of the quote-unquote standard donor criteria that were mandated for acceptability. For example, young age, a clear chest x-ray, absence of chest trauma, absence of aspiration, absence of a history of cardiopulmonary surgery, and absence of evidence of active infection. While these donor lungs are of perfect quality, they are rare in the current era in terms of frequency. As a result, multiple studies have examined whether some of these criteria can be liberalized, and the lung setting is just one example of extension of donor suitability criteria in solid organ transplantation. Here I demonstrate just one example of some of the studies that have examined potential impacts of donor acceptance criteria. These authors looked at donors who were below the age of 65 without proven impairments in lung quality after tobacco use of more than 20 pack years, the absence of parenchymal destruction related to chest trauma, and active donor management to maximize the function of donor lungs. In the setting of a unilateral abnormality, consideration of the use of the contralateral lung was determined. Another example of expansion of donor acceptance criteria is consideration of procurement after cardiac death. There are substantial differences between donation after brain death and donation after cardiac death. In particular, donation after cardiac death, because of the need to wait for circulatory arrest, which is of an undefined time frame, leads to an increased duration of warm ischemic time, which could potentially impact organ function. In addition, the capability to perform extended donor evaluation is limited in a donor who has not yet suffered true death. However, in experienced centers, donation after cardiac death has been performed successfully with comparable or superior outcomes to donation after brain death. Ex vivo lung perfusion is again one example of technological advancement that allows for consideration of extended criteria donor lungs. Here at the top left you can see the ex vivo lung perfusion circuit, and in the picture you can see lungs on pump. In the table is one example of a ventilatory and perfusion strategy for organs that are placed on ex vivo perfusion systems. The ex vivo perfusion system allows for a longer time frame for consideration of donor organs, which might potentially otherwise go unutilized. In some ways, this allows us to better optimize the donor organs for utilization, but also allows for potential complications related to mechanical support. Again, in experienced centers, the early and late complication rates associated with lungs that are placed on ex vivo lung perfusion compared to control lungs were not statistically significant. And the use of ex vivo lung perfusion to sustain organs until determination of viability is increasing in frequency. We have discussed the extended nature of consideration of both donors and recipients in the current era. Now we should move on to management of the transplant recipient in the ICU. Despite everything I've said already, it is important to remember that common things are common, and most likely in the ICU setting in the perioperative period, a complication is related to a standard ICU issue that you've seen in many other patients besides transplant recipients. In general, our approach to management of the ICU patient post-transplant is similar to that of other ICU patients. We use a standard ventilator approach with low tidal volume ventilation and a standard approach to weaning. Protocols and bundles that are used for other ICU patients should also be utilized in the transplant recipient. Minimizing sedation and delirium risk is of importance, especially in transplant recipients who may be on medications which can increase the risk of delirium, such as systemic corticosteroids. Aspiration and ventilator-associated pneumonia should be prevented using standard mechanisms, particularly in lung transplant recipients whose transplanted organs are especially susceptible to the potential impacts of such a complication. Patients should also be considered for standard venous thromboembolism prophylaxis as soon as is suitable from a surgical standpoint, and decubitus ulcer prevention should also be approached. In the postoperative patient with a fever, again, common things are common. Look for the routine causes such as ventilator-associated pneumonia, central line-associated bloodstream infections, and catheter-associated UTIs. The other standard complications that might cause post-op fever in a surgical patient include acalculous cholecystitis and decubitus ulcers. Also, remember that transplant recipients may be more susceptible to complications that are seen routinely in the ICU than other patients. Recall that these patients in the OR may experience hemodynamic instability, and in the setting of pre-existing organ dysfunction, which we already mentioned is becoming more common as we liberalize our recipient acceptance criteria, you may see organ dysfunction in transplant recipients more commonly than you might in other patients. These patients might also have prior exposure to nephrotoxins, which could make them susceptible to acute kidney injury. Immunosuppressive medications can also contribute to the development of transplant complications such as renal dysfunction. There are other complications that may also be more common in transplant recipients because of the impact of the surgical procedure itself. For example, ligation of the lymphatics and other drainage systems might increase the risk of capillary leak syndromes and volume overload, and patients may also be particularly susceptible to compartment syndrome. Patients who have undergone transplantation and require maintained open wounds may also be susceptible to infection. In terms of common complications in the ICU, these again may be more frequent in the transplant recipient. For example, venous thromboembolism is quite common in the transplant population, and in some subpopulations is even more common than in the high-risk populations such as orthopedic patients. Risk factors for the development of venous thromboembolism include older age, the history of diabetes, development of pneumonia, a history of idiopathic pulmonary fibrosis, an increased lung allocation score, which is a marker of severity of illness in the recipient at the time of transplant, cumulative ICU days, and use of mechanical circulatory support. Our own Brigham experience with venous thromboembolism in the lung transplant population demonstrates a greater than 30% incidence of VTE. The majority of these complications are deep venous thromboses. The majority are provoked related to interventions such as line placement, but in some cases have included fatal PE. Our approach has been to identify candidates who have a history of DVT and PE and develop a specific algorithm in the perioperative period for prevention of complications. We also have consulted with cardiology and the venous thromboembolism service, and our default choice for DVT prophylaxis in transplant recipients was changed to low molecular weight heparin in those without renal dysfunction or other contraindications to this drug. We attempt to initiate prophylaxis early post-transplant and continue for a longer duration than we might in other surgical recipients because of the high-risk nature of this complication. In addition to the common ICU complications that you would see in the general ICU population, there are indeed some specific complications that are unique to transplantation for which one should be aware. Primary graft dysfunction, otherwise known as reimplantation edema, is a relatively common complication in solid organ transplantation. Hyperacute rejection is becoming less common in an era of closer attention to ABO compatibility and HLA typing. Bleeding and infection can certainly be seen in the transplant recipient. Airway or other anastomotic dehiscence is also relatively common, as is vocal cord paralysis, diaphragmatic dysfunction, gastric hypomotility, and torsion of the transplanted organ. These are all things that should be considered in the transplant recipient who suffers early complications that are otherwise unexplained. Anatomic complications that are seen in solid organ transplantation include anastomotic stenoses, outflow tract obstruction, dehiscence or leakage, and torsion. In the figure, you can see the time frame after liver transplantation for some of these complications. The earliest complication is bile leak, which is associated with an anastomotic breakdown, and anastomotic stricture. Slightly later, non-anastomotic strictures can also be seen. And finally, the latest complication is ampullary dysfunction. Each of these abnormalities can be extrapolated to other solid organ transplant recipients. And you can also see that each of these abnormalities can occur a number of months post-transplantation. The potential etiologies for anatomic issues include technical disruption, a disrupted blood supply, which contributes to ischemia at the anastomotic site and in other areas, as well as the development of infection. Management of anatomic issues includes potential interventions such as dilations and stenting, and occasionally surgical revision of the anatomic abnormality. I mentioned that primary graft dysfunction is another common complication of solid organ transplantation. And in the figure, you can see some of the contributing factors. Recall that the donor experiences an injury that leads most commonly to brain death, occasionally to cardiac death. In both cases, both cold and warm ischemia is observed. This can affect the perfusion to the potentially transplantable organ, which can lead to disruption of its integrity. This disruption contributes to the recruitment of inflammatory cytokines and adhesion molecules and immune cell recruitment. This can lead to a capillary leak syndrome that is called primary graft dysfunction. You can see that this is associated with increased cell death and necrosis, increased innate immune responses, and increased immune cell recruitment. This primary graft dysfunction is associated with early allograft dysfunction and requires supportive treatment. In some cases, primary graft dysfunction can be severe and can contribute ultimately to chronic allograft dysfunction. Here is another schematic which demonstrates the association of ischemia followed by early reperfusion with migration of inflammatory cells that contribute to an inflammatory injury of the lung or other transplanted organ associated with a capillary leak. This is a diagnosis of exclusion, and the common complications must be ruled out before making a diagnosis of primary graft dysfunction. Each of the organ programs has a grading or staging system to determine the severity of the primary graft dysfunction and its potential association with later complications. In general, treatment is supportive, along with avoidance of secondary allograft injury. In addition to allograft dysfunction related to primary graft dysfunction, post-transplant infections are another common complication that can be seen in solid organ transplantation. Here you can see a schematic of the potential complications and their association with time post-transplant. Donor-derived infections can be seen and should be considered in an otherwise undifferentiated episode of infection in a post-transplant patient. These donor-derived infections can be either nosocomial or technical and may include activation of a latent infection or community-acquired infections which occurred prior to transplantation. In recipient-derived infections, in the early post-transplant period, again, common things are common. The most common infection that one sees in a post-transplant recipient who was colonized with organisms pre-transplant, such as a patient with cystic fibrosis who undergoes lung transplantation, is an infection that's associated with that same organism. Again, aspiration, catheter infections, and wound infections are often seen in our transplant recipients and are common in ICU populations in general. But recall also that our patients are often hospitalized in the pre-transplant period, and may be colonized with organisms that are associated with hospital-acquired infections. These should be screened for. C. diff colitis is again very common in the post-transplant period and can be seen within the first month of post-transplant care. It's also uncommon but not impossible to see an unusual donor-derived infection, and all of those described in this graph have been reported in case reports. In the first 1 to 6 months post-transplant, other infections are also seen. So in the renal transplant population, BK virus infection is very common and should be surveilled for. As well, C. diff colitis can persist during this time frame. Most patients are on prophylaxis for pneumocystis, but this should also be considered. Viral infections are also not unusual, and it's also not unusual to see opportunistic infections such as cryptococcus. In the absence of prophylaxis, one should also consider hepatitis B infection and in other opportunistic infections such as nocardia and toxoplasmosis. The majority of programs will perform serologic screening of both the donor and recipient and will assess the risk of transmission of infection from the donor and development of reactivation in the transplant recipient. More than 6 months post-transplant, community-acquired pneumonia and urinary tract infections can also still be seen, especially in the patient who has required prolonged hospitalization. But at this stage, the opportunistic infections become more common, particularly fungal infections such as Aspergillus and Mucor, and other opportunistic infections such as nocardia and rhodococcus. CMV infection, particularly reactivation, can often be seen, and as can rarer complications such as JC virus or Epstein-Barr virus-associated lymphoma. In the perioperative period, antibiotics are generally given empirically, but quickly tailored to the risk of infection in the center's microbiome. The majority of transplant recipients will also receive either prophylactic or preemptive therapy with valganciclovir or valacyclovir to protect against viral reactivation. For patients who have either donor or recipient positive serologic status for CMV, valganciclovir will be employed. The highest risk group is the CMV donor positive and recipient negative population. In recipients for whom the donor was negative for CMV IgG, as well as the recipient has no history of CMV IgG, valacyclovir may be used to prevent HSV infection. Antifungal approaches are unique to particular organs and programs. The majority of solid organ transplant recipients will be started on Bactrim prophylaxis for pneumocystis. And Toxoplasma positive recipients will receive daily Bactrim. And as mentioned, in the perioperative period, common complications are also seen in transplant recipients and should be surveilled for. It should be noted that transplant recipients often have low immunoglobulin levels, which has also been associated with C. diff infections and may place them at higher risk. Again, here's a schematic of risk of CMV reactivation or transmission from donor to recipient, going from highest to lowest. Again, the donor positive, recipient positive, and donor negative, recipient positive populations are of intermediate risk. More and more data is being generated regarding the use of antiviral preemptive therapy or prophylaxis to prevent CMV reactivation or transmission. You can see that the longer duration of use of antiviral therapy, the lower the risk of CMV reactivation or infection. CMV is also a risk factor for the development of rejection, and therefore the utility of prevention of reactivation or transmission is high. However, it is important to remember that these medications do come with side effects, most notably the need for management of the dosing associated with renal dysfunction and the development of leukopenia in extended treatment. It is also important to note that in the setting of lower dosing because of complications, the risk of antiviral resistant development of CMV is important and should be considered. CMV infection can cause viremia, in which viral load is positive but no end organ dysfunction is noted, and can also be associated with CMV disease. CMV can affect any organ in the body and most commonly affects the GI tract, the lungs, the eyes, and the bone marrow. Remember that leukopenia may be related to CMV treatment, but may also be related to active infection. Potential treatments again include valganciclovir, IV ganciclovir, and in resistant cases, foscarnet. Recall that foscarnet is associated with numerous complications, including renal dysfunction and electrolyte abnormalities. Not only CMV, but other viral infections have also been associated with complications in the post-transplant setting. Here you can see one example of a study that demonstrated the association of viral infection with the development of chronic rejection in lung transplantation. Each of the viruses listed here has been reported in association with complications of the allograft. We already mentioned Aspergillus infection, but this is a very common complication in transplant recipients, and it's important to be aware of the characteristics. At the top left, you can see a pathologic example of the Aspergillus organism. This is a branching hyphae that branches at acute angles. It is associated with multiple complications, most commonly in the airway or parenchyma of transplant recipients. Airway complications are almost solely unique to lung transplant recipients. The development of an Aspergillus infection in the airway can be associated with tracheobronchitis, airway dehiscence, airway obstruction, airway stenosis, and airway malacia. Recall that the limited blood supply to the airway, because of the disruption of the bronchial circulation, leads to the susceptibility of lung transplant recipients to infection of the airway with Aspergillus. Parenchymal disease can include ground glass infiltrates, alveolar consolidations, occasionally the halo sign, which is a ground glass consolidation in the orbit of an alveolar infiltrate. It can also be seen with bronchiectasis and can cause hemoptysis because of invasive fungal disease. Aspergillus can also be associated with disseminated disease. Management includes antifungal therapy. In the setting of a tracheobronchitis or other airway complication, topical therapy may need to be used for direct delivery to the airway that has, again, limited blood supply. Occasionally, airway interventions such as dilations and stenting may be needed to address the complications of Aspergillus infection of the airway. Rhizopus is another complicated fungal infection that can be seen in solid organ transplant recipients. At the top left, you can see an example of a pathologic specimen of Rhizopus. Recall that Rhizopus used to be called mucor. Wide hyphae are seen on pathology with few septations. When septations occur, they occur at right angles. Rhizopus can be a very resistant and difficult organism to treat. It can occur in the sinuses and can invade into the CNS. It can also cause pulmonary disease, skin disease, and other solid organ complications. Treatment can be difficult and may involve amphotericin. Surgical debulking is often also necessary. Recall also that Rhizopus can be associated with an allergic bronchopulmonary disease, similar to that is caused by Aspergillus. Actinomyces is also an infection that can be seen in transplant recipients, although not uniquely an opportunistic infection. Here you see an example of a pathologic specimen of actinomyces. It's an anaerobic organism that colonizes the mouth and gums. It can often cause lung infection due to aspiration. Actinomycosis causes a mass-like infiltrate in the lungs and can invade the bone, the muscle, and the skin. It often demonstrates itself without respect to normal anatomic planes. The actinomyces leads to characteristic sulfur granules on specimens that can be used to identify it. It may be associated with a polymicrobial infection, particularly in the setting of aspiration from the mouth. The treatment of actinomyces involves penicillin. If intolerant to penicillin or if resistant to penicillin, doxycycline and sulfonamides can be used. And remember that a protracted treatment course is often necessary. Rhodococcus is another opportunistic infection that can be seen in the solid organ transplant population. On the top left, you can see a pathologic specimen of Rhodococcus. This is an aerobic actinomycete that often can be confused with Nocardia or Corynebacterium. Rhodococcus can be acquired from exposure to both land and water animals. It is gram-positive and can look like either cocci or bacilli and can cause variable acid-fast staining. In the table included on this slide, you can see the numerous complications that are associated with rhodococcal infection, including pulmonary nodules and abscesses, wound infections, bacteremia, peritonitis, mesenteric adenitis, and hepatic abscess. Brain and renal abscesses can also be seen. Here is an example of a CT scan that demonstrates a parenchymal infiltrate that is associated with rhodococcus. Treatment involves susceptibility testing and often requires surgical debulking. Post-transplant lymphoproliferative disorder is another complication that is seen in the solid organ transplant population. PTLD is an Epstein-Barr virus-associated disease. Earlier development of PTLD is typically associated with a higher likelihood of disease that is limited to the thorax and may not require extensive chemotherapy. PTLD can be seen in the setting of an acute Epstein-Barr virus infection, which can be associated with a mononucleosis-like syndrome, including fever, malaise, pharyngitis, and tonsillitis. Other than the lung, the most common site of PTLD involvement is the gastrointestinal tract, and this can cause bleeding, obstruction, or perforation. Mass lesions can be seen in both the lung and the GI tract. An infiltrate of the disease of the allograft can be seen. It's also not unusual to see CNS disease, hepatocellular, or pancreatic dysfunction associated with PTLD. In limited stage disease, Rituxan alone can be enough for treatment. But patients who have more extensive disease or who are refractory to Rituxan may require broader chemotherapeutic agents. In addition to infection, rejection is another very common complication post-solid organ transplant. And in general, the management of a transplant recipient involves a balance between minimizing the likelihood of rejection and minimizing the side effects of the treatments that are used to prevent rejection. Mechanisms that contribute to rejection include primary graft dysfunction, as already mentioned, which can lead to augmented alloimmunity, damage to epithelium and endothelium, and airway fibrosis, as well as non-alloimmune insults such as infection and non-infectious complications, which activate the innate immune response. Autoreactivity is also a potential factor, and the absence or dysfunction of the regulatory T cells that allow for tolerance can contribute to the development of rejection in solid organ transplant recipients. Typically, an early and late form of rejection can be seen. Here are some examples of grading systems from the International Society of Heart and Lung Transplantation for acute cellular rejection in lung transplant. In general, acute rejection involves a lymphocytic infiltration of the allograft of varying stages. The more severe the lymphocytic infiltration, the higher the grade of rejection. In general, acute rejection is often responsive to augmented immune suppression. However, other potential inciting factors should be surveilled for in the setting of the development of acute rejection. Here are some examples in the lung transplant population of potential complicating factors. Close monitoring post-treatment is also often needed. Chronic rejection typically occurs later after solid organ transplantation and can be increased in risk by the development of acute rejection, CMV pneumonitis, and medication noncompliance. Other potential risk factors are listed here, and we mentioned that other infections, including other viral infections as well as bacterial and fungal infections, can potentially contribute to the development of allograft dysfunction. Older donor age and longer graft ischemic time can contribute to the development of primary graft dysfunction, which also can lead to chronic lung allograft dysfunction. HLA mismatching can also be a contributing factor to the development of complications. The management of chronic rejection involves modifying those potential risk factors that could be contributing, such as noncompliance or subtherapeutic immune suppression, antibody-mediated rejection, and other mechanisms of potential injury to the allograft. Augmented immune suppression should also be considered in this population. In general, tacrolimus has been shown in small studies to be superior in terms of prevention of acute rejection to cyclosporin, and in most programs has become the de novo choice for calcineurin inhibitor use. Similarly, the purine modulators, which include azathioprine and CellCept, have been compared in retrospective studies, with CellCept demonstrating some potential additional benefit, and consideration of switching from azathioprine to mycophenolate should be considered. Small studies have shown utility for anti-inflammatory agents such as azithromycin and statins. In general, though, an aggressive approach to augmenting the immune suppression and altering the T-cell response to allow for development of tolerance have been the mainstays of treatment of chronic allograft dysfunction. These potential treatments have included extracorporeal photopheresis, anti-lymphocyte therapy, and in unique occasions, repeat transplantation has also been considered. More and more is being learned about the impact of HLA mismatching and the potential development of antibody-mediated allograft injury. This has become an area of unique interest in the transplant population. The earliest studies to describe an antibody-mediated allograft injury described hyperacute rejection, in which neutrophilic infiltrates, endothelial and epithelial damage, and IgG positivity were seen. Hyperacute rejection was also often difficult to treat, but again is becoming less common with cross-matching procedures. In 2004, a publication outlined the criteria for the diagnosis of antibody-mediated rejection in solid organ transplantation. These criteria included evidence of graft dysfunction, histologic evidence of tissue injury which involved a capillaritis in general, immunopathologic evidence for antibody action, including C4d positivity, and serologic evidence of anti-HLA antibodies or other antibodies at the time of biopsy. In the setting of all four criteria, AMR should be strongly considered. Let's mention some of the non-allograft associated complications that are seen commonly in the post-transplant population. Our immune suppression, which includes calcineurin inhibitors, purine modulators, and corticosteroids, contribute to multiple medical complications after transplantation. These include hypertension, hyperlipidemia, renal dysfunction, diabetes, osteoporosis, and malignancy. The immune suppressive medications that we use to prevent rejection also are associated with numerous toxicities. Induction immune suppression can be associated with cytopenias, and calcineurin inhibitors in particular have multiple complications associated with them. Remember that the nephrotoxicity associated with calcineurin inhibitors is related to an afferent arteriolar vasoconstriction. This complication, therefore, can often be confused with prerenal azotemia. It is important to recall that while in the setting of high calcineurin trough levels, the risk of nephrotoxicity is higher, the chronic nephrotoxicity associated with calcineurin inhibitors can be seen in the setting of goal trough levels. CNS-associated complications related to calcineurin inhibitors include posterior reversible encephalopathy syndrome. Also recall that hemolytic uremic syndrome or a thrombotic microangiopathy can be seen in the setting of calcineurin inhibitors and should be considered in the setting of unexplained anemia and thrombocytopenia. Very commonly, calcineurin inhibitors lead to electrolyte abnormalities such as hyperkalemia, hypomagnesemia, and hypophosphatemia. The purine modulators, which include mycophenolate and azathioprine, can be associated with cytopenias, liver toxicity, and GI side effects. We also mentioned that typical prophylaxis regimens can also be associated with toxicities. In particular, valganciclovir can be associated with pancytopenia, not just leukopenia. And Bactrim, as you may know, is associated with hyperkalemia, nephrotoxicity, and leukopenia. So in summary, substantial overlap can be seen between general ICU care and care of the transplant recipient. Remember that common things are common. However, transplant recipients may be more susceptible to common ICU complications than other cohorts. Care of the transplant recipient requires a multidisciplinary and collaborative approach. While common things are common, please remember the special considerations that are seen in transplant recipients, including technical concerns, such as anastomotic complications and torsions, primary graft dysfunction, which is a capillary leak syndrome, immunologic issues that may play a role in allograft dysfunction, multiple infectious complications, and medication side effects. Okay, a couple of cases. A 56-year-old woman presents 1 year after right single lung transplantation for COPD. Her post-transplant course has been complicated by persistent neutropenia. She's been managed with tacrolimus and prednisone, but because of the neutropenia, she's required intermittent cessation of her mycophenolate. She's also received only intermittent CMV prophylaxis due to her neutropenia. She presents now with a 1-month history of increasing dyspnea and cough. She reports significant weight loss and poor appetite. She denies fevers, chills, or sweats. Her review of symptoms is otherwise negative, and she denies travel or sick contacts. She recently visited the state fair, but otherwise denies unusual exposures. Here you see her CT scan. On exam, she's afebrile. Her saturation is 96% on room air. Her exam is notable for diminished breath sounds in the native lung, but the allograft is clear. And a chest CT scan demonstrates a new infiltrate in the allograft. A bronchoscopy with BAL is performed. The patient reports improvement in her shortness of breath after empiric treatment with a fluoroquinolone. And 2 of 4 blood cultures subsequently returned positive for Corynebacterium, with medium suspicion for true pathogenicity based on the growth pattern. The most likely cause of the patient's pneumonia is Corynebacterium, CMV, nocardia, rhodococcus, or acute allograft rejection. The answer is rhodococcus. Recall that this patient visited the state fair, and recall that rhodococcus can be acquired from exposure to either water or land animals. In addition, rhodococcus can also often be confused with Corynebacterium. Question number 2. All of the following are potential causes of thrombocytopenia and coagulopathy after thoracic organ transplantation except bridge to transplant with mechanical circulatory support, induction immune suppression with antithymocyte globulin, preemptive fungal prophylaxis with micafungin, IV metoprolol for management of atrial fibrillation, or intraoperative cardiopulmonary bypass. The answer is IV metoprolol. Certainly, mechanical circulatory support and cardiopulmonary bypass can lead to a consumptive coagulopathy with destruction of platelets. Anti-T-cell induction immune suppression can also contribute to pancytopenia, including thrombocytopenia. And also recall that micafungin has been associated with thrombocytopenia.